What are the criteria for admission to the NICU? So obviously this would depend on your setup. Most of the units nowadays use phototherapy in the ward, postnatal ward, where the mother and baby are together. Intensive phototherapy, sometimes the baby needs to be admitted to the NICU in some settings. However, a definite indication for admission in the NICU would be signs of acute bilirubin encephalopathy. If the bilirubin is either at or more than the exchange level, and sepsis or ill-appearing child. You discuss with the neonatologist where the bilirubin level is above the exchange level to discuss appropriate blood products for arranging exchange transfusion. We have to keep this ready because it takes time for the blood bank to arrange, and it takes 4 to 6 hours. So even if you feel with the phototherapy it will reduce, you still have to make the arrangement. If the bilirubin level is remaining above the exchange level after 4 hours of intensive phototherapy, so we obviously have to involve the neonatologist for exchange. If the gestational age at birth is less than 35 weeks, baby is at high risk of progressing, and it's also more difficult to handle. Patients with immune-mediated hemolysis for either RH or ABO setting, where it is rising to either at or above the exchange level, there is enough evidence to show that IV immunoglobulin treatment may reduce the need for exchange transfusion by dropping the rate of increase. It works by blocking off the FC sites, swamping the system basically, and you will still need to continue phototherapy and monitor closely. So majority of the time, if there is immune hemolysis, we may prevent by using IVIG. Exchange transfusion can be prevented. The infants undergoing conventional phototherapy should not be routinely supplemented with IV fluids or formula. Breast milk is of course the feed of choice, and we should be careful not to implicate breastfeeding in the jaundice. So even if you want formula supplement, we should clearly educate the family that it is a temporary measure as an addition to supported breastfeeding, and we should also try to increase our mother's breast milk output and supplement the baby with express milk. Yes, since it will be for a short term, we should avoid bottle feeding. We should supplement with syringe or cup feeding. Lactation support should be given for every inpatient admission where the baby has jaundice and the mother is breastfeeding. Supplementary IV fluid should be given where the baby is clinically dehydrated, especially if the sodium is significantly high. We should be monitoring carefully, and it shouldn't drop rapidly. Where we have a total serum bilirubin approaching the exchange transfusion or above the level, IV fluids may help, but it's not essential to use it depending on the unit.